Add the slides, please. The next topic we're going to talk about is venous ulcers and wound care. We have a center that sees about 6,000 patients a year that have venous ulcers. And so what I'm going to talk to you about today, 6,000 visits a year, I'm sorry, not patients. That would be a lot. But what I'm going to talk to you about today is the management, what we believe should be the contemporary management of patients with venous ulcers. Well, this is a pretty common problem, as many of you, Dr. Marks emphasized how common venous disease is, but of all the population, at least 1% within their lifetime has had a venous ulcer, and at any one time, 0.3% of the population. Once they get a venous ulcer, and this is in a review article from Scandinavia, over 60% of patients take more than 6 months to heal, and 33% take greater than a year. And it's more expensive to our society in the United States than it is to treat a pressure ulcer, and we know how complicated those are. So it accounts for 2% of the healthcare budget. Now, I do want to just review again, you've heard a good review of duplex imaging, and I'm going to just emphasize that knowing the deep system, the superficial, and the perforating system is critical in managing patients with venous ulcers. And I'm sure you're all familiar with the deep venous system, the superficial with a great saphenous, and knowing that the posterior arch vein is the origin for what we used to call Cockett's and Boyd's perforators, and now we simply measure them above the floor because they are somewhat variable. So we'll talk about a vein that's or perforated that's 17 centimeters from the heel or 22 centimeters when we measure it in order to get it actually accurately documented. But this knowledge of these connections and also particularly at the saphenofemoral junction is critical to our understanding of how to manage venous disease and particularly venous ulcers. And I'm sure you're also familiar with the epigastric vein and the importance of the epigastric vein when we do endovenous ablation in order to prevent extension of DVT. Also, the small saphenous vein is typically will enter into the popliteal vein, but there is what we know call a vein of Giacomini, which in some patients continues up in the posterior thigh, can enter the saphenous system, it can enter the deep system, or it can enter the femoral system at a higher level than the popliteal. So there's a lot of variation in this venous anatomy, and also again in the perforating veins. The key to understanding venous ulcers is understanding reflux. And the most common form of reflux is in the saphenous system. You see in this diagram where you've got an incompetent valve, the black valve at the saphenofemoral junction, leading to reflux down the saphenous vein, and ends up in this patient creating lipodermatosclerosis due to valvular incompetence. I think we're also all familiar with the Seep classification system, and today what we're going to talk about is just the Seep 6s. And the clinical Seep 6 is simply an open active ulcer, and then it can be subdivided based on the etiology, whether it's a congenital problem, primary or secondary venous insufficiency, and whether it involves the superficial, deep, or perforating veins, and whether it includes both, either reflux, occlusion, or both. And these are just examples of patients in that this critical understanding of, and what we're talking about today is the Seep 6 venous ulcers. So historically, there have been a lot of approaches to venous ulcers. When I started my training, we had at Columbia in New York, we had a venous center where patients would come in for their weekly uniboots, and they would do this for virtually their whole life, never get any reflux corrected, and simply were used to either stockings, but often the uniboot or the compression paste for a lifetime of treatment. And then people began to realize that there might be some solution to that. Some suggested that the ulcer just be cut out and debrided. Actually, John Ricotta, who some of you know, had a large series of patients who had excision, which gets rid of the perforators directly into the ulcers and skin graft. And that was a good initial procedure, but it had a very high recurrence rate. We talked before about SEPS procedures, sclerotherapy, skin grafting. So there have been a tremendous number of ways of treating the venous ulcer, and that indicates the fact that none of them have been all that effective. And in fact, the classic paper from the group at Oregon Health Sciences, John Porter and Greg Mineta, is often quoted as showing how effective simple compression is. What's missed, if you really read that paper in detail, is that number one, patients had to be compliant with their compression and their support hose, but only a third of them had any of the ultrasound evaluation that Dr. Marks just told you about, and a very high percentage of patients did not in fact have venous ulcers. When you take the group of compliant patients out also, you realize that 22% of patients had a recurrence. So we know that patients who have just compression are not effectively treated simply with compression. So there have been a lot of options, and here you can see the SEPS procedure on the left. You can see the skin grafts that I mentioned to you before and the flaps, and none of them seem to be all that effective. So our principles in treating venous ulcers have evolved in the 10 years that I've been working at UCLA into this system where we try a wrap or compression for about 3 months. We try to eliminate the reflux and do the simple things, which are saphenous and small saphenous, demonstrating that there is reflux and then correcting it. We get rid of the tributaries that may be refluxing into the area of the venous ulcer. And then if that doesn't solve the problem, we go after the perforators. And we treat the perforators directly above or adjacent to the ulcer. And then finally, we use adjuncts like skin grafts, skin substitutes, even growth factors and stem cells to try to rapidly heal the ulcer once the patient has it. As I mentioned, there's some reporting standards. Dr. Marks has already gone over this. We try to get a vein that's at least 3 and often 4 millimeters in diameter with at least half a second of reflux, and for great saphenous and also for perforator. And we also use their criteria of pulsatility in order to identify patients who are the best candidates for the approach for venous ulcers. Now, this is a paper that we published on our contemporary approach with 1,000 consecutive patients that underwent the minimally invasive approach to venous ulcers. And you notice about 10% of our total population of venous procedures had an ulcer. We're going to talk tomorrow a little bit about the endovenous approach, but this just shows you the standard diagram of where in our case, we use radio frequency, and in our 1,000 patients, the majority of them were great saphenous. We had a few that had the small saphenous. And these were pretty large veins with an average diameter of 7.6 millimeters in diameter. When we look at our results, you'll see that about 10% of the patients had venous ulcers, and if we look at Seep Classification, that was 79 patients that had Seep. When we looked at the success rate, and one of the reasons why we use saphenous approaches first for venous ulcers is because we have essentially 100% success with closing the vein, whether it's the great saphenous or the small saphenous. And these patients rarely had problems, and they rarely had recanalization. And when you look at that group of patients, about 75%, 3/4 of the patient healed just simply with closing the saphenous vein or closing the small saphenous vein. There were 11% of patients who were treated who had persistent ulcers, and so of the 75%, 25% had persistent ulcers, and 11% of them chose to continue to be treated, and so those are the ones that I'm going to talk about now that have incompetence of their perforator system. And in this group of patients, as I said, we had very few complications. So we looked at the role of perforator vein, particularly treatment in Seep-6 ulcers in patients refractory. This is a typical venous ulcer. I think this particular patient had had this ulcer for 10 years, and it had not healed, and you can see this sort of chronic, scarred area of lipodermatosclerosis with an incompetent perforator. Now, for those of you who don't use an endovenous approach, we use the RFS catheter, and here you can see both the catheter and the goal of putting it in the perforator between the superficial and the deep system, and we try to position it right at the fascia if possible. And here you can see a diagram of under ultrasound guidance. In our institution, I do both the ultrasound and the RFS catheter simultaneously and find that that's really necessary in order to coordinate and to get the best closures. One of the things we found very interesting is photography, and we use a software program called Wound Expert and take a picture of every ulcer every week, and then we look to see whether it's getting bigger or smaller, and we outline it. And this is the sort of typical picture. This is actually a real patient who had a gradual growth in his ulcer. Every time we took a picture, it was bigger, and we finally did an ablation procedure. You can see how immediately the size of the ulcer turned around and it healed. So now we use that as our routine, as the size of the ulcer. And in this group of Seep 6 patients, you can see that as soon as you close one critical vein, which is either a saphenous or a perforator vein, patients begin to heal. And that occurs whether it's an axial vein like a saphenous, a perforator, or a combination of the two. When we look at our healing rates, you can see that the slope is and these are the patients that have been selected out that have an ulcer that's either staying the same or getting worse, so it's growing. We then treat them and get rid of the reflux, and you can see how the slope of the curve changes, and overall how, whether it's for a healed or unhealed ulcer, that's what they get. And this is just our group of patients. Here you can see where the ulcers started. Here's where the incompetent perforators are, perfect correlation. We closed them the black with ablation. We then closed a few more the second time around, and here you can see how the ulcers gradually disappeared. We still had a few patients who had ulcers, but most of them were high-risk patients who had some reason that they couldn't be followed. So our experience is that whenever you heal at least one perforator, that 90% of the ulcers healed when at least one perforator was closed, and none healed unless at least one was closed. And I will just mention that to remind you, as Natalie did, that one of the issues is that we have to look for proximal venous occlusion. And so here's the algorithm we use, which I mentioned in the beginning for all our patients. So the message that I would like to bring to you is that venous ulcers do not heal and stay healed unless they have correction of the reflux. Thanks.
Obrigado.